This is quite a few slides. It's on medications for diabetes. We're going to break it up with type 1 diabetes and then the type 2 diabetes. So I know you're covering diabetes in Med-Surg. I just thought I'd add this in here. The type 1 diabetic, their beta cells don't work. When it first hits, they have some, and it slowly goes down to where they have none. So they are insulin deficient. Their body doesn't make insulin anymore because the beta cells in the pancreas don't function. Type 2 diabetes, it's usually an insulin resistance where they have an insufficiency of insulin or the body cells are resistant to the insulin. And then there's other type of forms which mature onset and others that you should cover in Med-Surg or other classes. So insulin is needed for the glucose to enter the cell. This is a really good picture where the insulin is the key. It's not that the glucose isn't there, it just can't make its way through the cell wall. Insulin is that key to allow it entry. Also, the insulin is needed to promote conversion of glucose to glycogen for storage. Insulin inhibits protein degradation, and there are different types of insulin: rapid, short, intermediate, and long. And that is one thing you're going to need to learn is the different types. It's a picture of your insulin sites. You never massage after an insulin injection. It's always given subcutaneously. These locations, sites should be rotated. Never give it in a location that the muscle will be used for exercise right afterwards because that'll increase the absorption, cause hypoglycemia, and not last later. Insulin injections are always given between 45 and 90 degrees. All sub-Q injections are 45 to 90 degrees. The heavier a person is, the less of an angle, so 90 degree in an obese person, obese section. This is lithotripsy from insulin injections. You know, pictures speak 1,000 words. This is to help you understand what can happen after injections over and over and over in the same areas, increasing the need for proper administration and rotation of sites. Many ways to deliver insulin. Here they are: the syringe, insulin pen, jet injector, and an insulin pump. I've been around for all of these. We started with just this, and I've watched all this evolve. Some information here on your insulin pump that you should be aware of. Insulin pumps are small, computerized devices that deliver insulin in two ways. They give a steady, continuous dose, and that's your basal insulin, and they can do boluses. Usually they have a basal going, and they check their sugar throughout the day. They have some pumps now that actually checks the glucose also. But some have to do the finger sticks, and they do boluses according to their glucose, even though they have a steady amount going. Usually those boluses are around mealtime. Doses are delivered through a flexible plastic tube here called a catheter. There's a little dinky needle on the other side of it because it's subcutaneous. Catheter is inserted through the skin into fatty tissue, and it's taped in place. Usually, insulin pumps recommend changing that needle every 24 to 48 hours. Some have a soft cannula rather than a needle, and those are changed 48 to 72 hours. I think that's it. Okay, let's see. More information on your insulin pen, because you will teach people to do this. You may even have to administer them sometimes. Push injection button completely upon needle into the skin. If you notice, it's like like almost a 90-degree, or can be a 90-degree angle. That's probably about 70 degrees there. Do not pull out needle. This is the big thing. You push it, you hit until your tick sound, then dose scales to 0. Hold it for 10 seconds. That's the problem I have, and I've seen people inject and take it out. Hold it for 10 seconds because the insulin is making its way in. Do not let go of that button until you pull the needle out. Pull out needle, finish the injection, put on the needle cap, unscrew needle. So you change the needle cap after each injection. I've seen people not want to change those needles, but it comes with the pack of needles. That's another thing they need when they go get pens. Mixing insulins. Clear before cloudy. You have your NPHs and your regular insulins. These are cloudy, these are clear. If you notice here, if you're going to give, this is set at 30, you're going to give 30 units of NPH, you're going to give 10 units of regular. So you're going to put 30 units of air into your NPH. Then you're going to put measure 10 units of air into your R. Flip this over, pull out your clear, your R, and then go pull out your 30 of NPH. You have a total of 40. That will be a test question. Clear before cloudy. This is just a good picture. You never want to contaminate your cloudy with your clear. If you can't remember, think about it. Regular insulin is short-acting, rapid-acting, or short-acting. Your NPH, your cloudy one, is intermediate-acting. You don't want to mix a short or rapid-acting insulin with an intermediate-acting, because if you think you're only giving an intermediate and don't expect it to peak for 4 hours, and some regular or short-acting gets in there and it peaks in 30 minutes to an hour, you're going to have a drop in sugar unexpectedly. Teaching on insulin storage. You can read this. Regular is the only insulin that can be given IV. There's some rapids, I think, that have come out that you can give, but for the moment, it's still NCLEX reviews. They're still saying regular insulin is the only intravenous. The rest of them are only sub-Q. Insulin cannot be given by oral route because your acids in your stomach will destroy it and you will absorb none of it. So it has to be given parenterally, which means other than through the intestines, and it is given sub-Q, and regular is only one IV. Insulin can be stored at room temperature for 4 weeks. Otherwise, it needs to be in the refrigerator. Best to let it come to room temperature before you inject it. Insulins are not shaken. You take the bottle and you rotate it in your hands the way you do if you're drawing blood. You're going to rotate it between your hands to mix it, everything except regular insulin. If your insulin is discolored, you are to discard it. Insulin comes in 100 units per mil and 500 units per mil. The 500 unit ones, more and more of those are coming out. Make sure you're looking at your bottle because quite a difference. 100 units in 1 mil versus 500 units. So if you grab a 500 and you think you grab a 100, you are going to mega overdose them and cause complications and possible death. All insulins parenterally, sub-Q. Okay. I think I've got all that covered. So, most of these are pictures. You can come back and look over them. Rapid acting insulins. You have, these are like, I would say immediate or rapid and short acting. You have your Humalog or Lispro that acts very, very quickly in 15 minutes. That's the one you're going to make sure have food ready or ingested when giving Humalog or Humulin R, more so your Humalog Lispro because it is rapid acting. Duration 3.5 to 5 hours. So it lasts a while, but it kicks in immediately. And then your Humulin or your regular insulin, which is your short acting, I think that's supposed to peaks in 2 to 5 hours. Oh, that's 0.5. And I was going to say a half hour. So this Lispro in 15 minutes, your Humulin R or regular insulin 30 minutes to an hour, peaks in 2 to 5 hours, and lasts 6 to 8 hours. So it lasts through the day. Regular can mix with all insulins. Lispro can only mix with MPH lente and ultra lente. And both of these can be used on sliding scales. They have to monitor their glucose. Here's just another image to help you on the time frame of when an insulin kicks in. There's your Lispro, which is your rapid actings. Here's your regular, which is short acting, NPH intermediate acting, and then you have your long acting or basal insulins. And however you need to do this, you need to get these in your head. You need to have an understanding onset, peak, duration, onset, peak, duration, because you have to plan for this. So I gave you lots and lots of pictures, images to help you learn these. These will be test questions because this will be on NCLEX. So 4 different ways to help you with them. Regular insulin is the only one IV. Lispro is like your endogenous, like most like the insulin that our body makes, and it's the fastest acting. Rapid acting have to be given with meals. Never mix a long acting or long acting with any other insulin. Those are your basal insulins. Roll insulin in your palms. Do not shake. Discarded, discolored. Room temperature 4 weeks. I said about the U100 and U300. There is two Sheo. What is that on here? It's not on this one because it's a long acting, not in this picture. 2JOs, a U300. We'll get into that. Okay, we'll get into those. Oh, 2JO goes somewhere in here, but it's not on this old picture. Okay, let's keep moving. Found this. I thought this might be helpful. Fast acting, no lag period. Long acting, LLL. Levemir Lantus. Lispro Aspart Glucine for fast acting, intermediate. Isophane, that's your MPH. And then ultra long acting or Digludex. Intermediate and long actings, your MPHs and your basals are never used in emergency. Okay. Normal glucose levels. These are your normal glucose levels in blue, hypoglycemic, and significant and down insulin shock is less than 50. These are fasting and post-meal for a person without diabetes, and this is where you hope to get the diabetic into these ranges. Be familiar with these because I don't know yet, I may ask questions related to what you're going to do. So if you know what your norm is, or when you're in danger too high, you know if you're adding sliding scale, holding insulin, calling someone. Okay. Complications of hypoglycemia. Cold and clammy, need some candy. Cold and clammy, need some candy. Easy way to remember it. You treat it with giving 15 grams of rapid-acting sugar or 25 to 50% glucose solution. That's a D50, comes in this little bottle that you inject IV, depending on your situation. Glucagon can be sub-Q, IM, or IV. People will have a packet of sugar or suck on a candy if they can. If If they're not responsive, usually diabetics will carry a little packet of glucose that can be squirted under the tongue, because if you remember from pharmacokinetics, it goes right in your vascular system. Here's another with cold and clammy, need some candy, and tired, T-I-R-E-D. Signs of hypoglycemia. That's an excellent mnemonic to help it stay in your head. Glucagon first aid kit for severe hypoglycemia. This is lots of information. As I said, it's 15-gram rapid acting sugar, or you give 25 to 50% glucose solution. This glucagon is given IM, sub-Q, or IV. Do not use your glucagon unless the solution is clear. And note that glucagon interacts with anticoagulants such as warfarin or Coumadin. If you're on an anticoagulant, you have an increased risk of bleeding. Enoxaparin, which is a heparin. Oh, God, I can't think of the word right now. Okay. Anyway. Diabetic ketoacidosis, I think I heard Dr. Decker talking that she was covering in that, although we usually don't really go into that until MedSurg 3. But here's some information for you if she is covering it. Pharmacologically, you will give IV fluids, IV fluids, IV fluids, IV fluids. So 8 to 10 liters of normal saline to replace the fluid loss. It's half normal or normal, but usually you're going to give normal saline, which when we talk about fluid and electrolyte unit, we will cover more of that. It's an isotonic. It doesn't pull fluid in or out of the cells. So you get 8 to 10 liters of fluid replacement. For DKA, you only give regular insulin, closely monitoring your glucose and your potassium. I'm pretty sure I have a slide later that talks about potassium and the shift of potassium. Insulin decreases potassium levels in the blood by redistributing it into cells. A large part of shifted extracellular potassium would have been lost in urine because of osmotic diuresis. So you can anticipate when you're giving insulin in DKA that the glucose is going to drop. So if your potassium is normal at a 5 and your glucose is 500 and you're given regular insulin, you're also going to give potassium because that potassium is a false level and it's going to be shifting into the cells as the glucose comes down. Diazoxide increases blood sugar by inhibiting insulin release from beta cells, stimulates epinephrine, not indicated for hypoglycemic reaction, usually for a chronic hypoglycemic. It is rare for somebody to be truly, truly hypoglycemic because they actually have a little mass that's producing this insulin. So it's really, really rare. So I have actually never seen this drug given. Lots of people will claim to be hypoglycemics, but they're not. And here we go. Also, hyperinsulinism due to islet cell cancer or hyperplasia. So that's when this is used. So just familiar with it, diazoxide is for that. After all that, we're finally to type 2 diabetes and lots of treatment options for this. Okay, so your type 2 diabetes, let's keep going. I should have discussed that in MedSurg. Just some risk factors for type 2, just gave you a picture, but again, should be covered in MedSurg. Here we go, on oral antidiabetics. Oral antidiabetics are only for type 2 diabetes. The type 1 diabetic, this is not effective because you cannot boost insulin production because their beta cells are no longer producing insulin. Absorbed in the GI tract, they are not insulin because I said there is no such thing as oral insulin because it cannot be absorbed in the GI tract. metabolized in the liver, excreted in the urine and feces. Criteria for use. I think I have these slides very written up for everything you need to use. This was onset usually at age 40 or older. For oral antidiabetics, that is changing as our society's BMI is changing. Diagnosis of diabetes for less than 5 years because the beta cells get less functional over time and they will become ineffective. Fasting blood sugar less than 200 for an oral anti-diabetic, otherwise they're going to be needing insulin. This, less than 40 units of insulin required per day, that's criteria that are written for most of these normal renal hepatic function because of it's metabolized in the liver and excreted in the kidney. Okay, biguanide or metformin, first line. It is the first line of treatment for type 2 diabetes. Decreases the glucose production by the liver. May decrease possibly decreasing the absorption of glucose in the intestines, and also improves insulin sensitivity, makes the cell, the insulin receptor, more. It helps the insulin receptor be more receptive, I guess you could say. Does not stimulate insulin release, so not associated with weight gain or hypoglycemia. No hypoglycemia with metformin. These are your metformin, biguanides, continued. That's the class it is. It's the only biguanide that is on the market is metformin. First line, been around forever. Less likely to cause hypoglycemia, very low risk because it's not increasing insulin production. Adverse effects, GI upset, bloating, and diarrhea. That usually decreases over time. So usually you start them on a dose for a couple weeks. They get some diarrhea, it starts to subside. You change it to twice a day. They get a little diarrhea and gassy, and that subsides usually in about 4 weeks. It's excreted by the kidneys, so contraindicated for renal disease or dysfunction because that's how they get rid of it. Contraindicated alcoholism and hepatic disease because of the liver, and contraindicating heart failure. This hypoglycemia, although it's less unlikely, it will interact if they're on cimetidine, which if you remember from GI drugs, cimetidine is your antagonist, ranitidine is your Zantac. Those are both H2 blockers or H2 antagonists. So combining metformin with an H2 agonist cimetidine or ranitidine will increase your risk of hypoglycemia. Sulfonylureas are the next class. We're now using this as the second generation of sulfonylureas. They stimulate insulin secretion from beta cells. So you need some functional beta cells still because it's kicking. I say it's kicking those beta cells, tell them to work harder. These are your ones: glyburide, glipizide, glimepiride. If you notice the "ide" on the end. Glyburide, glipizide, glimepiride, they all begin with a G. These are sulfonylureas. Adverse effects: weight gain, definitely. Skin rash, nausea, I've seen some of that. Interaction causing hypoglycemia if given with, again, your cimetidine and ranitidine, just like with your metformin. Hypoglycemia if given with sulfonamides, salicylates, and alcohol. Salicylates are your aspirin products. Pepto-Bismol has salicylate in it. Sulfonamides, any kind of sulfa drug. There's a few different drugs that are in the sulfa class. And again, it's given early in diabetes, type 2 diabetes, and you have to have still some functioning beta cells. These are your hypoglycemic risk. You have a risk of hyperglycemia if a sulfonylurea, glyburide, glipizide are given with a thiazide diuretic. Most common thiazide diuretic is hydrochlorothiazide or HCTZ, so increased risk of hyperglycemia. And also, although it's not an actual sulfa drug, if they have an allergy to sulfa antibiotics, sulfonamide, such as Bactrim, which is a sulfa drug, there is a risk of like a cross sensitivity. Not definite, but a risk. Next class are your glynides. They're similar to the sulfonylureas by increasing insulin secretion. They have a short acting, so they're good for postprandial hyperglycemia. That's people whose glucose spikes after meals. So with their meal, they take these with their meal to prevent postprandial hyperglycemia. Repaglatinide and metaglycinide. Don't mix these up with the ide sending. If you see here, aglinide for a glycine, aglinide for glycine, and you give it with your meal. TZDs, or your glitazones, TZDs is what you'll hear, inhibit glucose and triglyceride production by the liver. Real good for that person with hyperglycemia and high triglycerides. You will see that combination quite often. Triglyceride normal in a high, max high where you want it is 150. I'm talking people with triglycerides of 1,000. And I don't know how they're not in pancreatitis. Insulin sensitizing, so it helps your insulin work better, makes your insulin receptors, that key, more sensitive. Takes several weeks. They're not going to drop the sugar right away. It starts inhibiting that glucose, making you use your insulin better, so it takes several weeks to be therapeutic. They don't get hypoglycemia because it's not literally kicking those beta cells. It's proven benefit because cardiovascular risk, because this triglyceride and slowing down that glucose absorption. You need to monitor your liver function levels like every few months to make sure they're okay. More on your glitazones, major effects: weight gain, peripheral edema, a black box warning, and heart failure. TZDs are not given if they have heart failure. And remember, your TZDs are glitazones. Back here. Sorry, I didn't realize I had not put the names on these slides. Pioglitazone, Pioglitazone, is Actos, and rosiglitazone, Rosiglitazone, which is Avandia. So they both have glitazone in their name, and your glynides have glynide in their name, and your oh my goodness. Okay, so decreased bone density, so there is a risk for fractures with glitazones or TZDs. Pioglitazone, rosiglitazone. Risk and black box warning, not to be given in heart failure. AGIs, alpha glucosidase inhibitors. There's only one, arquebus. If you can remember the alpha for arquebus. Delays glucose absorption temporarily, prevents postprandial spikes, no hypoglycemia or weight gain. Must take with first bite of food. If you notice here where I said it delays glucose absorption, prevents postprandial spikes, and it has this temporary delay in glucose absorption, so you give it the first bite of food to prevent that glucose absorption. Can cause elevated liver function tests, so obviously you're going to be monitoring your liver function tests. With things like this, AST, ALT, possibly bilirubin are the main things. Keep going. These, I said, called your AGIs, reversibly inhibit an enzyme in intestines responsible for breaking down saccharides. It blocks this, leading to a block of glucose absorption. It must be taken right with the first bite of food, prevents that postprandial or after meal spike. Do not give if you have intestinal issues. See your adverse effects, flatulence, diarrhea, abdominal pain. You're going to contraindicate in inflammatory bowel disease. That is your Crohn's and your ulcerative colitis. It's a autoimmune disorders with the function malabsorption syndrome, intestinal obstruction, because that's exactly where this works, is in the intestine, inhibiting an enzyme in the intestines. So you're not going to give this to a person with problems with the intestinal tract. Gliptins, these will often be called your DDP4 inhibitors. They inhibit this GLP-1 in the cycle, allows the insulin levels to increase postprandial, suppresses glucagon secretion after meals. So it allows that insulin to go up and suppresses the glucagon secretion. Adverse effects, upper respiratory infections. I have actually seen people end up really with a sinus infection or pneumonia on a GLP-1 or gliptin. Headache, fairly common. Diarrhea, I've seen some. Possible pancreatitis. So you're really watching if they have a history of pancreatitis, alcoholism. You are not going to give this to them. And it interacts with digoxin, which is your linoxin. If they're on that, digoxin is one of those drugs that has a very, very narrow therapeutic index. So increased digoxin levels are dangerous, and so it can interact and increase those levels. So this inhibits the GLP-1, which is an incretin hormone released by the GI tract in response to food, and that's what it suppresses. See, incretin mimetics, if you remember from pharmacokinetics or basics of Pharm, mimetic means it mimics. So it mimics this incretin or hormone that your body releases in response to food. So by mimicking that, it enhances the glucose-dependent insulin secretion. So it mimics this, and your body says, oh, I need to produce more insulin. Obviously, you need functioning beta cells for these. Suppresses elevated glucagon secretion. So, your glucagon is to raise your blood sugar. It slows the gastric emptying. It's only given subcutaneously. And for type 2 diabetes only, it is not insulin. You have to have functioning beta cells for your body to produce this. It slows the gastric emptying. It slows down the absorption there. Another slide on your GLP-1s are your incretin mimetics. These are alba-glutide, dulaglutide, liraglutide. This one just has the tide ending. The rest have the glutide for GLP glutide to help you remember those glutide endings. It slows down that absorption, so it actually results in weight loss. They can lose 5 to 10 pounds. Adverse nausea, vomiting, diarrhea, possible necrotizing pancreatitis. So you're definitely watching those amylase lipase, which is your pancreatic enzymes. Definitely watching those. I have seen people with such significant nausea, vomiting, diarrhea that they refuse to continue. Sometimes this will settle down. I've had people that are willing to take it for a time. I have not given Tansium. I have done the Trulicity, the Byetta, and the Victoza. I've seen really good results with Victoza. Anyway, because it's slowing down the function here, slowing gastric emptying, you have to think about it. It can then decrease the absorption of oral medications, so you have to teach on the timing on these glutides, Byetta, Trulicity, Victoza. These, which ones? This dulaglutide is one that is given, both of these, alloglutide and dulaglutide are given once a week. And I think these are daily, but these two up here are GLP-1 Exidon mimics that are given once a week to enhance insulin secretion, increase the beta cell responsiveness, suppress glucagon secretion, slow gastric emptying, and gives them a feeling of fullness so they actually will eat less. SLG2 inhibitors. There's only the one, Invokana, canagliflozin. I will give you that with the Invokana name in it if I test you on it. Blocks reabsorption of glucose in the proximal tubules of the kidney. So if it's working in the kidney, blocking that absorption, you want to make sure that you have adequate renal function and that you're monitoring that renal function. Contraindicated if kidney isn't functioning well. What are you looking at for kidney function? You're looking at your BU and creatinine, possible creatinine clearance. Creatinine clearance is a urine test. BU and creatinine are in your labs, part of your basic metabolic panel. May increase insulin sensitivity and glucose reuptake by muscles. So it helps you not reabsorb as much and your insulin work better. Give it in the morning. There's a low risk of hypoglycemic. By helping with this glucose reuptake, it actually can result in weight loss. Sometimes it is the only drug they need, Invokana. Sometimes it's given with other things, but again, it is given in the morning. Contraindications, obviously, kidney impairment, which I said. Contraindicating DKA, it is not something that's going to lower that glucose right away, so it is not given in the insulin crisis of a DKA, diabetic ketoacidosis. Obviously, think about this. The genital yeast infections, UTIs, increased urination because what it is doing, it is blocking reabsorption of glucose in the kidneys. So there's more glucose going through the kidneys coming out when you pee. So yeast infections down there because of the sugar. The UTIs because of the sugar. Increased urination because that urinary frequency because of the glucose. So obviously you would expect to see glucose in your urine if you were doing a test. Other adverse, hypotension, hypovolemia, hyperkalemia. Remember your insulin and your potassium. So if you're dumping glucose out in your renal, if you're not reabsorbing, the potassium is going to be hung onto. So hyperkalemia. Remember your most of your your potassium, you're looking at 3.5 to 5. So hyperkalemia is a potassium greater than 5. Hypovolemia, losing volume because that sugar is going out in your urine and your water is going with it. Hypotension, because you also might be losing some sodium there, you're losing volume. Hypovolemic, low blood pressure. Black box, increased risk of foot or leg amputations. And I've not quite figured out why, but I have seen this where there's lawsuits out there because of this increased risk for foot or leg amputation. It's just an old picture I had. Some people may work better with this, but some people will also find this too busy. So it's up to you whether you want to use this. That's where I broke down it as much as I could. Almost to the end. Other anti-diabetic agents, only one is the Simlin, pramlintide acetate, approved for type 1 and type 2 diabetes, improves postprandial glucose control, who are using insulin but unable to achieve or maintain glucose control. suppresses glucagon, slows gastric emptying, modulates appetite by inducing satiety, making them feel full. That's all on that one. Okay, so you got to teach lifestyle, 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 lifestyle. Insulin, food choices, exercise, the whole circle around and around. I thought that was a cute picture. It's the only way I can get him to exercise. Here's some more. He's not talking about the football game. He tested his blood sugar and he's happier with the number. So here we go. Actually, that is the end of this glucose management recording.